Welcome, everyone. I'm Dick Deming. I'm Medical Director of MercyOne Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. And our topic today is speech therapy. And I have two outstanding speech therapists and team members. We have Joy Hesse from Iowa ENT and Sydney Brotherton from MercyOne Riverside Rehab Center. So welcome.
Thank you.
So let's learn a little bit about you first. So Joy, let's start with you. Where are you from? Where were you born?
Oh, gosh. So I was born in a little town straight north of Des Moines, Alden, Iowa.
Okay.
I grew up in a family where my dad was a severe stutterer and my mom had a severe hearing loss. So I grew up in kind of a speech disordered family early on. And so that is how I got interested in the field of speech pathology.
So you went to high school in Alden, and then
I went to University of Northern Iowa for both my bachelor's degree and my master's degree.
And the University of Northern Iowa has a long-standing history of educating speech therapists, or the technical phrase is speech language pathologists.
Yes.
We use the shorthand of a speech therapist.
Yes.
So when you study speech language pathology in college, do you get right into assessing patients early on, or is it more like medical school where the first 2 years are classroom and it's not till you're
kind of like that? I would say they have a clinic where then you're able to see patients. Back 35 years ago when I was going through school, they focused mainly on public school and like speech pathologists working in the school with children.
For children.
Yep. And so my class and I were kind of the first to break out of that mold and go into the medical setting.
Gotcha.
So
because UNI is strong in elementary education.
Yes.
So it was natural that the speech language program sort of
would also be that.
Yeah, was hand in glove with school age kids.
But yep, I said I like my own children, but not so much everybody else's. And so I'm like, I'm going to go into the medical setting. So,
okay, excellent.
It was good.
And Sydney, what about you? Where did you grow up?
I grew up in Eldridge, Iowa,
Okay.
and then I went to UNI for both my bachelor and my master's degree as well.
And when did you realize that was a profession you wanted to pursue? Right when you started college? Did you realize it in high school?
A little bit in high school. My mom's a special ed teacher.
Okay.
And so I had seen speech therapists, in the schools. And then once I got into the program more, I realized I liked the medical side of it a little bit better. So, yeah.
And you both mentioned that you have your bachelor's and your master's. Was that kind of a seamless, you go from bachelor's to master's, and you pretty much have to have a master's before you can start
to get a
taking
degree
care
in speech pathology.
Okay.
Yep. So you don't have a choice.
Gotcha. And since both were at UNI, they just said, you have that seamless program where you go right from bachelor's to master's. Joy, what was your first job after you got your master's?
Actually, my first job was at Mercy Hospital. I did an internship there, and then they kept me on. So I actually helped to set up the modified barium swallow studies 35 years ago.
I
was
did
in
not
on that.
know that.
Yeah. So I was there for 6 years.
What was your first year there?
89.
Okay. That's when I started.
Oh,
was
yeah.
1989.
That's so funny.
Okay.
Yeah. We go way back.
And Sydney, your first job out of training?
I worked in the skilled nursing facilities in smaller towns outside of Des Moines just for 9 months. And then I came to Mercy.
Okay. And you've been at Mercy for how long?
2.5 years. I came at the end of 2020.
Okay.
Yeah.
Great. So one of the reasons we have you on the Cancer Education Series is speech therapists play an enormous role in the type of cancer we call head and neck cancer. So head and neck cancer, for those who may not know, could be everything from cancer of the mouth, the tongue, the back of the throat where the tonsils live, or the base of tongue, or it could be cancer down around the voice box, the epiglottis, the vocal cords. Those all fall into it. Or it could be cancer like a lymphoma that happens to be in the neck that isn't a traditional head and neck cancer, but the treatment especially the radiation, might cause some issues.
Mhm.
Tell us a bit about the various forms of assessments. And let's start with assessments. So before you even get to treatment, because you guys are important in evaluation and assessment and actual treatment. So what's involved with the evaluation and assessment of an individual who might have head and neck cancer?
Yes. So we try really hard, and you guys are wonderful about sending patients proactively. And so it's important that they get to a speech pathologist before their treatment even starts. And I know people are puzzled by that, but initially I will get measurements of their head and neck. I'll measure how wide they can open their mouth. So we'll get some objective measurements. We often will also do, it's called a FEES, which is an instrumental swallow evaluation, where we look at the impact that the tumor is having on their swallow before their treatment even starts to see, are they safe to be eating now? And then we know.
And by safe, the thing that makes it not safe is if food goes down the windpipe.
The wrong way.
That goes down the wrong pipe. That's
exactly
one of the really dire consequences of abnormal swallowing.
Correct. So that is kind of our evaluation. And then we try to see patients kind of through, and then for sure when they're finished, because there's certainly things that we can do before, during, and after that will make a huge impact on the quality of life way down the road.
Yeah. Let's stick with the evaluation for a second. So, and I might not use the same terms you would use, but there are various ways of assessing swallowing. So one way is a direct visualization, where you use a fiber optic scope, where you're actually visualizing the lower throat, the hypopharynx, the larynx in the act of swallowing. But then there's also times where we send a patient to the radiology department and they do a sort of a video x-ray of the patient swallowing various consistencies of foods. Are you involved in both of those procedures? And when do you do one and when do you do the other? And
yeah, that's a great question. So I am within an ENT office, and so I only do the flexible fiber optic method that I personally do. It depends. I think that we tend to refer if we're worried about esophageal issues or oral issues, because those can't be seen with my scope. And so it just depends on their symptoms that guides the treatment or that recommendation.
Okay.
Yep.
Sydney, how would you?
Before meeting Joy, I sent people for video swallow studies in the radiology suite, but I definitely see the benefit of FEES because you can see, their tissue, you can see exactly what's going on, what it looks like, and the residue after, I think is super helpful to see.
And let's define that. FEES. Is that an acronym? That
Is.
Yep. Fiber optic endoscopic evaluation of swallowing.
Okay. FEES. Fiber optic endoscopic evaluation of swallowing. Gotcha.
Yes.
Okay. And so, as you said, it's important. It's valuable to have that assessment before you even start treatment, so you can say, what is this patient's baseline? And then many patients with head and neck cancer get a combination of surgery, chemotherapy, and radiation. Sometimes the surgery is just a biopsy and they get just chemo and radiation. And there are different side effects of chemo radiation. I mean, when you're getting the treatment, it's basically inflammation and some swelling. But then after treatment, you can really get lymphedema and fibrosis of the neck. What are some of the treatments that you do to help with patients who are experiencing either swallowing dysfunction because of the tumor or the surgery or the side effects of the chemotherapy and radiation?
Okay. So lymphedema, I start like during that initial evaluation, I have them start doing their own manual therapy for lymphedema for the head and neck.
And most people, when they hear lymphedema that are cancer survivors, are probably thinking breast cancer and the arm. So we're talking about a different part of the body. So maybe describe what lymphedema looks like for someone who has lymphedema after head and neck cancer treatment.
Yep. And so typically you will see, like we used to lovingly call it the turkey wobble.
Mhm.
And so a lot of times they get swelling kind of right down the middle. But really, any type of swelling in through the neck, the jaw, the face. And then we also know that you can have like swelling on the outside, but I'm more concerned about the swelling on the inside because that's what impacts the swallowing long term.
So if somebody has severe lymphedema, as you look in, you might see that the caliber, that the diameter of the opening has been diminished.
Mm-hmm.
Mhm.
And so if the swelling at the back of the voice box, and hopefully we'll be able to show that,
Mhm.
if it's very swollen there, that's where the esophagus begins, as you know. And so that's when they start to have issues with more solid foods going down or not able to
Mhm.
swallow at all, airway issues. So that's
And-
something we need to be very aware of.
And what are some of the techniques you use to help reduce lymphedema in the neck and the head and neck
Yep.
region?
So external lymphedema, I know you've talked about it before, is treated with, there's kind of 4 parts to that. One is compression. So we have them get a compression garment that is fitted around the neck and comes up around the head. And so it covers all of this area.
And just compresses.
Yep.
the
And so it
soft
holds
tissues.
that they wear at nighttime, they wear at bedtime. Exercise, I know you're big on that. And so we want them to exercise, and swallowing is the best exercise for swallowing. So we need them to swallow. Elevation, making sure that they're staying upright. They're not, sitting like this all day long with their head forward. And then manual therapy is the other part where we go through, it's a series of just a gentle massage, working that lymphedema or that fluid. It drains down and out through your chest, basically.
Mm-hmm. So the lymphatics of the neck drain down and basically get back into the circulation.
Yes. And so it's kind of a combination of all 4 of those. And then for the internal lymphedema, we're finding success with a deeper tissue massage where we kind of work deeply into and around the larynx because that's where that swelling is.
Can you do massage internally, or does the gag reflex usually prevent you from, in most patients?
Yeah, most patients, yeah. And so I do a lot inside the mouth. With glossectomy patients, there can be swelling of the donor tongue.
Right.
And also
So patients that have had part of their tongue removed,
yeah.
then they often will replace it with some muscle from the leg or the arm, and that's usually very bulky.
Yes, but you can work on that tissue and get it pretty pliable and greater range of motion, and usually they do pretty well getting back to a fairly regular diet.
Yeah.
But internally, no, we can't, but it's right underneath here. And so depending on how you're moving that tissue, I've had success with getting that lymphedema to move out of the internally as well.
And give us a sense for, so you're going to do a external massage type lymphedema treatment. Is that 10 minutes, 20 minutes, half
45
hour? 45 minutes.
Yeah. It's a good workout. So my therapy is usually, I tell people, you don't want me to just sit here and watch you eat. That isn't good use of our time. You want my hands to be on your neck and working on you. And so I might do a little bit of, it's called bolus driven therapy, where I want them to swallow hard food. I don't want them to drink while they're eating. I want them to make those muscles work hard. Gotcha. And so I get that through their head. And so we work on swallowing hard and getting the food to go. And then I work on their neck.
Okay. And do you have, are there certain standard foods that you have them eat or swallow while they're in your office?
Yeah, we march through the progression. So you start, we start with what they're safe with. And so that's what the instrumental test is determining first, what are you safe to eat and drink? And then if they're safe with, say, liquids only, then we slowly work them up into purees. And once they're safe with puree, then we go to soft and then regular, and then foods that they avoid are always foods that I want to get to, like pizza or hamburger.
Okay.
Yeah.
So they get to come to your office and have pizza?
Well, I have like the bland foods, but
Okay.
they bring, like I say, I need you to bring
I
this,
see.
and then
So you
I'll
ask
warm it up
them
for
to
them.
bring them.
Yes.
Okay, gotcha. Okay.
Or they'd say,
Gotcha.
I need a steak.
Yeah, that would be interesting if insurance covers.
Yes, I had a
Steak dinner.
T-bone
Yeah, please, a filet
my
mignon.
speech
and
therapy.
Speech therapy.
Yes.
Yeah. Okay. And Sydney, what would you say? Do you think so? You've trained at a bit of a different time. As you collaborate now, so Sydney's getting some mentoring from Joy.
Yes.
Do you think the techniques have changed over the years in terms of the type of treating of lymphedema from?
Well, and so in school, I didn't learn lymphedema. I have learned everything for head and neck cancer from Joy, but I think swallowing wise, the treatment has changed a lot. Where before, people got a feeding tube and they pretty much stayed on that, and we're putting on thickened liquids, and we're on that for a long time as well. Where now we're trying to get people back to things that they want to be eating.
And I would assume, but correct me if I'm wrong, that in training in college, you probably didn't get a lot of hands-on with a fiber optic scope.
No, yeah. I didn't touch a scope till I met Joy either.
Right. So, and I would imagine that Joy, a lot of your hands-on skills, because you're embedded in an ENT office, where scoping a patient is like
16 a day.
It's
yeah,
like taking a blood pressure in another patient's
yes.
in another doctor's office.
Yeah,
It's
yeah.
not a big deal. It's something that you do
Every
time
day.
and time again. And so you've been trained by the ENT folks to do that, and that has
Yes.
become an important part of your evaluation.
Yeah,
of their
evaluation
swallowing.
and treatment. Like I use it in treatment too for biofeedback.
So tell us how you use it for treatment.
So with treatment, a lot of times with our head and neck cancer patients, we know that they're aspirating. Like they're aspirating, and as long as they're, pretty healthy and up, mowing their lawn and running and doing their normal things, they can tolerate that.
A little bit, they cough it out.
Yeah. And so a big part of therapy is figuring out compensatory strategies. And so the scope is good for teaching them how to hold their breath, or why I need to turn my head, or why I need to, do this, whatever, to make my swallow safe.
So when you say it's biofeedback, you're having them look
Watch the
at the
screen.
monitor. So they're
Yes.
actually, while they are breathing or swallowing,
Swallowing.
or they are seeing what
Yes.
is it happening
Yes.
inside.
Why do I need to do that?
Gotcha.
Yep.
And so then they get to be able to sense the feeling with a visual by looking at the screen.
This picture is worth so much. Like they understand, why am I having this trouble? I can show them, the base of your tongue is withering away. It's weak. So now that's why we need to do these exercises. And then, 2 months later, they can see that, oh, that looks better.
Gotcha.
So, yeah.
Gotcha. Well, let's have a demonstration. I know
Yes.
you were kind enough to bring fiber
My
optic
stuff.
scope and your monitor, and also Sydney has graciously volunteered
Yeah,
to
you can
be
go
the
get your
subject.
trays, Yeah.
So we're going to do a little rearranging of furniture here. So go ahead and get situated. So Joy is going to do a FEES, a fiber optic endoscopic evaluation of swallowing. Sydney right now is putting using some spray in her nose that has a topical anesthetic and a decongestant, so that it will open up her nasal passage and make it numb, because Joy is going to insert the fiber optic scope through her nose and then be able to look down into her throat. So this is the fiber optic scope. You can see it's got a it's a fairly small diameter, like a straw, with a light on it. Yes. So Joy's, the handle there has where she steers it. So let's look at the tip as you maneuver it before you put it in. So So as you use, you can move it right, left, up, down. So as you're putting it in there, you can maneuver it to be at the right angle to visualize. Okay. You can be where it's ever works best, and we'll move the camera around. And George, you want to move should we move the chair so you have a better angle with the camera?
Sorry, someone was messing with my picture. All right. So I always say everybody has hair at the front of their nose.
Yeah, and George, if you want to come around so you can see the tube going in to the nose here. So Sydney, we're moving the camera around and
All right. Tell me when George is ready. You see that?
I think what we'll do is move your chair so that the back of your chair is not the other way.
This way?
Nope, with the back of the chair facing the door, and even a little farther rotate. Yeah,
This way?
that way. Yes, that way George will be able to get on camera, and he can get on camera you moving. And he's not quite there yet. There we go. So there is the end. And Joy's going to be inserting that into her nostril.
All right. So at the front of the nose, off to the right is her septum.
And then we'll go ahead and George will visualize the screen. So the screen is just what we are seeing. We're now visualizing the hair in her nose.
Yes.
And now the scope is going through the nasal cavity. You go ahead and describe, Joy.
Okay. So so now I'm in her left nostril. So off to the left is her septum. And then I'm trying to go, underneath, it's called the inferior turbinate. And so inside your nose, there's 3 turbinates that are the filters. They're about the size of your pinky. I am killing you. Am I killing you? Sorry.
No one is being killed. I just want the records.
No dying. No dying. No.
We're not ramming a hose.
No. She does have a hard nose. Okay, so now I'm past the worst part. So this is called the adenoid. Adenoid is like a tonsil that sits at the back of the nose. And then now I'm going to go down. Sydney, go ahead and swallow for me. Get a better picture. All right, so the first thing we come to here is the very base of the tongue, or called the lingual tonsils. And this is what gets weak with head and neck cancer patients when they're not eating and swallowing. And so you see atrophy, or that kind of shrinks or goes away. Then this little thing is called the epiglottis. That is a little leaf-shaped cartilage that helps when we swallow.
And that's kind of the trap door, right?
Yeah, it is the trap
that
door.
It goes over, so we're looking at the vocal cords, but when you swallow, that
go ahead and
little
swallow,
trap
Sydney.
door, there you go. It closes
flips
over the windpipe so the food doesn't go
down the
windpipe.
wrong pipe. Yes. And a lot of times with cancer, with the radiation therapy, the epiglottis gets very swollen and very stiff. Sometimes it doesn't work anymore, but that's okay because we can work around that. But thankfully there's 3 levels of protection for your airway, and the epiglottis is just one of those protections.
So that V structure, what is the V structure?
So those are the true vocal folds. So that's what we
cords.
talk and sing with. And then under them is...
Give us a high C, Sydney.
E.
There we go.
And so the vocal folds are actually moving more quickly than the human eye can see. And so in the office, we have a fancier one that has a strobe light. So we can actually see the vocal folds oscillating Yep, these called a mucosal wave, and so you can see the slow motion movement of the vocal cords with that. But with this, with girls, ours are moving about 200 times a second. With men, about 100 times a second, opening and closing. How cool is that?
That is cool. And of course, women are overachievers. They have their vocal cords oscillate at twice the speed.
And I'm sure most men would agree with that. Yes. All right. And then the kind of knobby things are called the arytenoids. They open and close our vocal folds. And then back at the back part here, that is the opening of the esophagus. And so that gets pulled up and open as we swallow. So that's where the food goes down.
So whereas the trachea is wide open, the esophagus in its normal state is collapsed.
It's closed. Yep.
So you don't see a hole, an opening there.
No.
So when you swallow something, it goes right where that sort of crease is. That opens up and becomes a opening where the food goes down.
Yep. And there are shelves, kind of normal shelves that we have. One is at the back of the tongue. That's called the vallecula. And then there's these two off to the side called the piriform sinuses. And so if you've ever had a pill or a popcorn hole stuck, it's probably sitting in one of those little pockets. With head and neck cancer, if the tongue starts to go away, then that vallecular space gets enlarged. So lots of people complain of food sitting in their throat. And so it becomes a big shelf where the food goes down and sits. So that's a huge thing.
Yes, it can become infected because the food we have some bacteria.
Yes.
And sits in that
Pockets.
And can develop an infection there.
It's yes. And so that's when a lot of times people start taking a drink to wash that down. And then that just lets the muscles continue to get weaker and weaker. So that's what therapy is about, is like retraining and making sure that all of these muscles stay strong.
Can we demonstrate a swallowing?
Yeah.
While we're
You wanna
visualizing?
grab-
So we'll
yeah.
have Sydney's got some water and she's going to suck in a little water through a straw, and then we're going to see the act of swallowing here.
So you could kind of see it dump down because
Yeah.
she's a little bit numb. You could see it dump down to, it's called the piriform. But with a normal healthy swallow, it's not very exciting. You don't see very much.
Right. That trap door just closes, moves over
And the throat.
windpipe and
And the
base
throat.
of tongue.
Yeah, the throat muscles collapse almost like a python. Like it just squeezes down. So everything squeezes down around. And that pushes the food down into the esophagus. So it's pushed and kind of sucked down in.
Okay.
Very good.
Excellent.
You want to sing?
Oh, I'm not a good singer. I can do
E.
Okay.
And now go E. E. So it's like a little instrument inside us. Good. All right.
Thank you, Sydney.
You did good. I forgot you had a bad nose. Should have let you so meet.
That's all right. I don't mind. I should have it done if I'm doing it to people.
Okay.
Just look like that. So you don't trip on it. How about
Yeah,
that?
there we go.
So, Sydney, what did that feel like while the scope was going in?
Oh, yeah, let me flip this around. It doesn't hurt. It's just a little bit of pressure.
There's a little bit of pressure
Mhm.
as the tip finds its passing, because it's not
Yep.
a direct. There's some twists and turns.
jigging and
that you have
jagging,
to
yeah.
make, and
Yep.
the turbinates can be a little bit more pronounced, and there can be some lack of symmetry. So,
Yeah.
Deviated septum, yep, or yeah.
Mhm.
but obviously, a procedure just requires a little topical anesthetic. It's done in the office.
Yep.
If you were doing the evaluation and we weren't talking through the whole thing, probably would take you 5 minutes to do it.
Yeah,
or-
it kind of depends. And so one of the good things about our test is that you're not limited by radiation exposure. And so we can, if a patient is having trouble, they can bring an entire meal And like I've had them
Gotcha.
last 30 to 45 minutes.
Right.
So they
Whereas
can-
if they're doing the video x-ray, there's a limit to how much you can expose
right.
them to radiation as they're going through the
Mhm.
swallowing, because their body's getting exposed to radiation.
Radiation,
This is you're just
Yep,
there
you
with
just
the camera,
watch
just
them.
watching.
Yeah.
Mhm.
So as long as my arms hold up, we can go.
Uh-huh. Good. So in an ear, nose, and throat clinic with, you've got on any given day, how many doctors would you say you have there on a given day? Three or
three
four?
or
And
four,
then you're
yeah.
there,
And
and
then-
people are being. How many scopes do you have, and how long does it take to process a scope from one patient to the next patient?
Yeah, and so I can do anywhere from 6 to 16 scopes a day.
Same scope?
No, well, like you take the scope and then I have a half an hour or an hour, depending on. So I'll allow an hour for a swallow test on my schedule, and then a half an hour if I'm looking more at voice issues, or like a recheck for head and neck cancer. And it takes 8 minutes to process the scope through the disinfectant.
Oh,
So it's,
okay.
it's
So
just
it's only 8
yeah, it's
minutes
a high
to
level.
disinfect.
It's a high level disinfectant at 8 minutes, and then a 1 minute water rinse, and then it's ready to go.
Gotcha. So you would use the same scope every day. It's not like you alternate scopes.
Yes, we have 3
Mhm.
because we have so many, but
Yes.
yeah.
Okay. Great. Any other comments about the technique of doing the fiber optic examination from either the patient perspective or do you have some patients that are just apprehensive about it, and even the idea that you're going to put something in their nose?
Yes. So, I mean, you obviously have a few people who just say, no, I'm not going to do
they start
that.
backing up.
Yeah. They're like, well. But then I sometimes say, I just did this on a 3-year-old. So, and that will usually
I just did this on a 90-year-old. She tolerated
and she
it just
did just fine. So I'll sometimes try that tactic.
You're not really going to whip out on me, are you?
But usually what people say is that they're very apprehensive, but then, once
let's just give it
you
a
talk
try.
about it and you explain it, then at the end they're like, oh my gosh, I can't believe I was so worried about that. Like, so I promise it's not that bad, is what I say.
Okay.
Yeah.
Sydney, any other? So you're learning to do the technique.
Yes.
What has been your perspective in learning to do it?
I think it's great to be able to see what's actually going on with people swallowing or their voice, or, what we're doing on the outside and how it's helping on the inside to make sure that we're providing the best care for the patient. It's been really cool to see that. And I think, a lot of the people that come to the ENT, which is where I see most of the scoping right now, they came because they had a problem and they want to see what's going on. So I had a patient that I was watching with Joy the other day when she stepped out of the room. He was like, she's going to do something today, to like help me with this. And that biofeedback, it's cool to see that she can help people the day they go to the
Like,
doctor.
I have a treatment plan.
So one thing that I sometimes experience, so a patient might have some potential swallowing issues. And I say, I'm going to send you to a speech therapist. They, well, my speech is fine. There's nothing wrong with my speech. And the point I'm making is that obviously a speech therapist, there's many different aspects of head and neck you work with, but swallowing is probably a more common thing for you to work on with the head and neck cancer patients. Now, patients that have cancer not of the throat, but of the front part of the tongue where they've had part of their tongue removed. Well, there you get into also
Speech,
imagine
intelligibility,
the speech techniques. Maybe describe a little bit, what does speech therapy look like? How do you do it? How do you instruct patients or actually move their tongue?
Yeah. So with glossectomy patients, it's about, sometimes they don't have very much movement of the donor tongue portion of it. And so then it's figuring out, like, if I can't make a K or a G sound, then can I make a different sound from my throat, or can I substitute a different sound in a different way? A lot of times it's slowing them down, having them over articulate, pretending like they're talking to someone who's hard of hearing. Those are all, my goal is always to get them to be 100% intelligible, both in person and on the phone. And that we can usually do that.
Mhm.
Yeah.
Yes. How about individuals, and this doesn't happen as often now, but where they need to have a tracheostomy or a permanent ostomy,
Yeah.
so they have their larynx totally removed and an opening for the air to go directly into the trachea, and then the voice box is gone. What are the various ways of allowing them to have intelligible speech if their voice box has been removed?
Do you want to do that? You want me to do that?
And that's all you.
I got it.
You're the
Okay,
voice girl.
okay, yeah. So, yeah, when I started, that was my love. Like I was one of the first ones to go for tracheoesophageal puncture training
Mhm.
with,
Maybe
35
explain
years
what that
ago.
is.
Yeah. So,
Tracheoesophageal puncture.
with laryngectomies, you have basically two choices. One is an electrolarynx, and that's the little device that you either hold up to your neck or you might use a little adapter in your mouth. And I'm sure people have seen them. It sounds like a robot and they kind of talk like this. And then you just teach them how to articulate really well. But they can be very, very intelligible with that device. The other way, which is super cool, is with the laryngectomy, they actually, like all of the larynx is gone and they reroute the trachea to the front of the neck. And so they have to have a stoma. So they have an opening here. And what they do is they create another little tiny opening inside this stoma. So an opening that goes from the trachea into the esophagus. And then we place a little prosthesis, a one-way valve into that. And then they can talk by using their thumb, or there's covers, and that gives them a voice where then the esophagus is the vibration instead of the vocal folds like we saw.
Gotcha.
Then the esophagus becomes the vibrating source.
So the air goes from their lungs through that
The
one-way
one-way
valve into
valve.
their esophagus and then up
It vibrates
out through the mouth.
Yes.
Gotcha.
And then they can speak hands-free a lot of times and be very, very intelligible with that too. Kind of a rough, raspy voice, but a voice. Yeah.
Right. Okay. Other roles that speech therapists play in head and neck cancer. If we left anything out, we talked about the lymphedema. I would say there's also the muscle stiffness that can happen.
Yep, fibrosis.
Fibrosis of the muscles
yep.
that you can work on.
Yes, so we work a lot with the front. Swallowing, voice and airway, like those are concerns too a lot of times. You know, sometimes if they have a paralyzed vocal fold, there's breathing exercises that we can go through.
Gotcha.
And then
Because in
voice.
some types of cancer, so for example, lung cancer, if they've had cancer in the lymph nodes in the upper center part of the chest, it might press on a nerve that causes one of the vocal cords to be paralyzed.
Yes.
So there are techniques that you help with breathing,
And their
speech,
voice. Yep.
and usually, does swallowing become an issue too?
Can,
because the vocal cords can't close.
Yep. So it's like a trap door. And so if one part of your door doesn't close, they would usually have issues with thin liquids typically, but that's usually pretty easy to deal with, head turn or something like that. But yep, we do a lot. Anything with voice, airway, and swallowing are the big things.
So the older one is, the more likely they are to get cancer. So some patients who have cancer, maybe not of the head and neck, but are of an age where they're starting to get some cognitive decline, but also swallowing can be affected with diseases like Parkinson's disease. And there it becomes aspiration become a problem in that situation. Are there techniques you use to help with swallowing?
Yeah. A lot of times with Parkinson patients, it's just teaching them strategies that will help them, remember the technique. So I'll make a cue card that's, using an effortful swallow, or if we saw on instrumental that a head turn's beneficial, things like that. Slowing down is a big thing for patients with Parkinson's. Slow down while you eat, small bites, things like that. More for the cognitive side is just reminding them of how to be safe while swallowing and using the compensatory strategies if we saw that they were beneficial.
Okay. We're going to transition a bit. I said we might do this if we had time, and I think we do have time to talk about this. So many people don't realize that speech language pathologists or speech therapists also play a role in cognitive issues. So, for example, a patient may have a brain tumor or may have had a stroke or may have Alzheimer's disease, and their cognitive abilities are affected. What's the role of a speech therapist in helping with cognitive language therapy?
Cognitive linguistic therapy, I typically try to keep the patient as functional as they can be, or that they're at when they come to me. So I set up external aids, whether that's reminders on their phone, sticky notes around their house.
Before you get to that, how did a speech therapist become the person who does this?
Oh, I don't know.
Such a good question.
Because cognitively, this idea of language, knowing what we want to say and getting everything to work that the word comes out is a language skill. And so the idea of language and memory are kind of intertwined. So that's become your part of your role in cognitive impairment. So with my brain cancer patients, they might come to your rehab center and see a physical therapist and an occupational therapist and a speech therapist. So it's common they might have all three of those in a brain injury situation.
Yep. So, I don't know how it came about that way.
I bet it started like with stroke patients. Like if you'd have a left hemisphere stroke and they're dealing with language, but then also higher level functions like memory. So I think it's probably just kind of evolved from, aphasia, I would imagine, if you've had a stroke.
And maybe in some centers, I don't know if the occupational therapist
they do some too.
Does some of that as well, because it's sort of, but anyway, I interrupted. That's back to what are the techniques that you use for someone who's got cognitive impairment to help them with memory and just the activities of daily life.
So a lot of that is, like I said, the external aids, or just compensating for it in other ways, or teaching them memory strategies, like repeating it in their head, writing it down. I really like using the association strategy, having them associate it to something personal in their life to help them kind of remember whatever it may be. Things like that is kind of how I approach it. Like I said, I don't like to have them come and, remember 3 pictures and then tell it to me in 5 minutes. I like to think about, okay, do you need to remember your grandkids' names? How can we remember that? Do you need to remember to take your pills at a certain time? Let's put a timer in your phone. Things like that.
Okay. And are there common, when someone starts to experience cognitive impairment, it seems like names are often one of the first things that they struggle with.
I do that association strategy a lot for people's names, or I say bring in a picture of them and write it on there and put it on your fridge, and every morning you wake up and you repeat their names with the picture. So visualization can be helpful as well.
So if you have a patient in your rehab center that let's say had a stroke and is recovering, and they're coming and they're seeing PT, OT, so PT, physical therapy, OT, occupational therapy, and speech therapy. How do you guys and gals coordinate the care of that patient if they're seeing all 3 of the therapists? Do they typically come into your rehab center and see all 3 of those services on the same day?
Typically at our facility, I would say 75% of people come in and see all of us on the same day. And I always try to get me first or second, because patients will fatigue a lot throughout therapy. So they do. We try to make it a cohesive care, or sometimes we co-treat. I did that a lot when I worked in the skilled nursing facility with patients co-treating, or some of the pediatric patients we co-treat, just to help keep the time that they're spent there down.
Okay. Well, I think we're going to open it up for questions. So we have a live studio audience, and they look very much alive. And then we also have folks that are live streaming. So if you're live streaming, you can put the questions in the comments section, and we'll open it up first to our live studio audience.
I am one that has the raspy voice, although it sounds pretty strong on the microphone.
There you go.
And you touched on this. I have a vocal cord that was damaged while getting a trach put in. Are there any procedures that could increase my volume so I could be loud like I am right now?
Yeah. And so fortunately, there are several procedures actually that can be used. Have you tried therapy?
No.
Okay. So a lot of times we'll start with therapy because that's the easiest and the cheapest. And like, I know I won't hurt you in any way. Then a common treatment for vocal fold paralysis is called a vocal fold augmentation or injection. So they literally use, I don't know if you know, like what they put into women's lips to kind of puff them up a little bit, like make you, not Botox, but it's like a filler. So like collagen, exactly. And so they use that. And there's one that's very temporary. So if you're worried about, how would my voice sound, we can use one that melts away within a few months. And then there's also more permanent ones that typically last years. But we can oftentimes get the voice sounding close to or normal.
So it doesn't it doesn't bring the movement of the vocal cord back,
Correct.
but it just kind of puffs it up.
Correct.
So that it allows the voice to be louder.
Yep, it allows the good vocal cord to meet the one that's damaged. Yep. Yeah, we don't have a way yet to hook up the nerve and make it work again, but we're good at compensating for that.
Yeah, I'm thankful that, I still have a working one, but
Yeah.
if I could be louder, there's times.
Yeah, definitely. We can help you. Yes.
Great. Great question. Thank you. Another question.
Yeah, I have a quick question, or maybe it's a quick question. You touched on it just a little bit, the gagging effect. So in your demonstration, we saw it go through the nose and down. I think that you might be able to go through the mouth and down if you do that or
Yeah,
not.
so I have two ways that I can look at your voice box. One is a scope that just goes into the mouth, no further back than where you brush your teeth. And then the other one is the scope that I did here.
Okay. And then we saw a little bit of prep here off camera where you put that stuff in
And
your
that
nose
Afrin and
that would
lidocaine.
numb it.
Yeah.
But it would seem to me if I did that, even if I had that, the gagging effect would kick in just like that.
Yeah,
You got a lot of people with the gagging effect, and with the people who are chronic like that, what do you do with them?
Yeah, good question. So the Rigiscope that goes into the mouth, if you're a heavy gagger, like if you gag on your toothbrush every day, then a lot of times that won't work. Or if you start to gag when my scope is out here, then I'm like, nope, you can't do that. But when we use the nose one, that actually bypasses the gag. Like the gag response is here. And usually we just go behind it. And so rarely do I gag someone when I use the flexible scope, believe it or not.
Okay, thank you.
Yeah.
I have another question for you real quick. And this is cancer related, and you're using your scope and you're going down and you're looking for a cancerous type of tissue.
Yeah.
What does that look like? And what's that type of experience for you?
And so I have many, many pictures of cancer everywhere. As you can imagine, you've seen that. Usually cancer looks rough and irregular. A lot of times it's white compared to the surrounding tissue. We just had a patient the other day and he had something on his vocal fold, but it was pretty round and smooth. And so I was like, I hope that's not cancer. But in general, cancer looks irregular and rough and ratty. You think?
Yeah, and there's two subtypes. There's a type that's sort of lumpy bumpy that kind of looks like a raspberry. So it's kind of bumpy, not as regular as a raspberry. And then there's some that can have an ulceration. So they've got like a hole in the middle with a raised edge around it. So those are two different techniques.
Types.
And sometimes the cancer can be under the surface and you see a normal appearing surface, but you just see asymmetry where the right and left don't look the same, and there's sometimes in the base of the tongue, the cancer is actually underneath the surface, and you're seeing an asymmetry, but the actual lining, the outside layer of the tongue looks normal. So those would be some.
Yeah.
of the
Yep. For sure.
descriptions.
Asymmetry. Yeah.
And then you mentioned the white. So there's a pre-cancer that's called leukoplakia, and that just stands for, it's Latin or Greek for white tissue or white plaque. White plaque.
Yep.
White
Plaque. Yep.
And that can be an area of concern. So sometimes that leads the ear, nose, and throat doctor. I assume you're not doing the biopsies.
No,
No,
I'm
it's
just
the ear, nose, and
looking.
throat
Yeah.
doctor. But that might direct them to say, gosh, we should biopsy this to see, is this a pre-cancer? Is it a cancer?
Yep. Exactly.
Mine is on lymphedema. So with your lymphedema patients, do they use like a flexi touch?
Yes.
And how long is that process?
and
is
so-
it daily?
That's fairly new, probably in the
And maybe
last 5
repeat
years.
that,
Yes.
And what is that?
Yeah. And so there are, for different types of lymphedema, like in the arms or legs or trunk, there are pneumatic compression devices that have been developed for many years. And within the past 5 to 6 years, there's now one specifically for head and neck cancer. It's a vest and then a headpiece, and it does what my fingers do, probably better than what my fingers can do. So you can do it at home. And I usually recommend, we found it to be very, very helpful with our head and neck cancer patients, with the lymphedema, oftentimes also with their swallow, with getting increase in their salivary function. So many, many benefits with it. And I usually at the beginning, I have them using it 2 times a day. Sometimes they do it before every meal. So sometimes they do it up to 3 times a day. And then as they get further out and the lymphedema is controlled, we go down to once a day. And then a lot of times they can kind of back off and do it, episodically. But lymphedema is something that can flare up, as people know. So
I have a follow-up question. You mentioned something that we haven't touched on. One of the common side effects of radiation therapy is dry mouth. And we haven't touched on that, but the dry mouth, our saliva every second of every day helps fight bacteria. So not only do you feel uncomfortable with dry mouth, not only does it affect taste and swallowing, but it also increases dental decay because you don't have that. Do you think that manual therapy helps restore some salivary function, or if we've blown the salivary glands with the radiation, there's not much you can do?
I think it depends.
Okay.
It depends on the patient for sure.
Mhm.
There was actually a pretty recent study where I think it was China or somewhere, Taiwan or maybe somewhere, but they did during their treatment, they did manual therapy themselves
Of the salivary
of
glands.
the salivary glands, and then intraorally, and they had less mucositis, they had less pain, they had improved swallow and salivary function. And so I've actually added that. So I have patients, there's sets of salivary glands here and under the tongue and then under your mandible or your jaw, chin. And so we have them working on those salivary glands. And when I do my manual therapy, I can see and feel that I stimulate saliva.
Yes.
Yes.
Excellent. Thank you.
Yes.
Other questions? Kevin?
Yeah, the patient also can taste that saliva too.
Yeah.
But I just want to point out, I spent many sessions with you, Joy.
Yes.
And only one small fraction in one session had anything to do with the fiber optic evaluation. Most of the time, Joy has a whole array of exercises you can do to maintain your swallow function, keep your saliva glands functioning, moving liquid through your lymph system, keeping the tendons in your neck flexible. This she'll keep you busy for a long time outside of that flexible evaluation.
Great. Well, thank you for your testimonial. Yeah. Thank you, Kevin.
There's a lot.
Yes, so many side effects from head and neck chemotherapy and radiation. Getting through the treatment and being successful in getting rid of the cancer is a necessary step, but lots of lingering side effects that affect quality of life, where the role of a speech therapist is so important.
Now, I've got a question, kind of a curiosity. With your scope, when you're looking at someone's vocal cords, if you're looking at a singer, a vocalist, I mean, can you tell a vocal athlete? I mean, can you see that with your scope? Is it different than an average person?
Yeah. So I have two parts to my practice. I have my head and neck cancer patients, and then I have my professional voice users. And so, like, we're the house doctor for the Des Moines Opera and for the Civic Center. And so I see kind of scary voice boxes, and then I see beautiful voice boxes with beautiful singers. But if you showed, they usually, if they're truly a vocal athlete and they're like an opera singer or a music theater person, they don't look perfect. Just like, runner's feet aren't typically, beautiful feet, but you can tell that it's an athletic event, because that's what, singing is. And, probably even the broadcasters for you. Yeah.
Now, what about a hard rock singer? And there's been where they can cause damage. Yeah.
Yes. And so we work on trying to, make sure that their voice and their singing technique are as healthy as they can be. But it's usually this balance of, with a rock singer, it's hard because they're like screaming.
Right.
So a lot of it is, what do I do when I'm not on stage?
Mm-hmm.
Yeah.
But if you're called in, okay, you got the star of the musical going on.
Yeah.
They're calling you in. It's not like they're wanting lifestyle changes for the next 10 years.
No.
They want to go on stage that night. So is it like
the,
spraying a little bit of steroids on their vocal cords?
No,
or
you
what do you
give
do?
them a shot.
You give them a
of
shot of
Decadron.
steroid, shot of Decadron.
Yes.
Gotcha. So it's not a spray of Decadron on the vocal cords. Okay.
Nope.
Okay.
Give them a shot in the butt.
Gotcha. There we go. Well, the show must go on.
Yes.
The show must go on at the Civic Center, but right now the show can't go on because we're out of time. So this has been great. Joy Hesse, speech therapist at Iowa ENT, and Sydney Brotherton, speech therapist at MercyOne, Riverside Rehab. Both playing instrumental roles in helping us take care of head and neck cancer patients and helping keep them as functional and a great quality of life.
Yes.
So thank you so much. If you know someone that would benefit by watching this, it will be available on demand tomorrow at the Above and Beyond Cancer YouTube channel or the MercyOne Cancer website. And I hope you'll join us again next week for our next edition of our cancer education series. Thanks, everyone.